Thank you all for staying with me. I appreciate that you're not went shopping. So the last talk is on the recent published ESPGHAN guidelines. The ESPGHAN is the European Society for Pediatric Gastroenterology, Hepatology and Nutrition. And last year they published a very comprehensive guideline on parental nutrition of premature, newborns and also children. I'll focus on the prematures and on the newborns today. The guideline has about 14 chapters, more than 100 pages. There are several chapters on macro and micronutrients, standardized versus individualized nutrition, and also on how the guidelines were established, how the evidence level is. On central venous access is one chapter, and one chapter is on home parental nutrition. And due to time resources, I focus on macro and micronutrients and on standardized versus individualized nutrition. So, first of all, who needs parenteral nutrition? These are very nice recommendations from the American Academy of Pediatrics. And they define that all infants with a birth weight below 1,500 grams should have parenteral nutrition. These are the infants usually admitted to the NICU. We also have a reference value for these infants, and usually they stay for several weeks and are not able to digest from the first day on. The late preterms sometimes stay with the mothers in the nurseries, and it's not necessary sometimes to give them parenteral nutrition. So what is our goal? You've heard before that our goal is to establish growth. Growth is we want to make the infants grow according to the intrauterine growth velocity, and this is approximately 17 grams per kilogram per day. And what we as neonatologists also want to do is we want to avoid extrauterine growth retardation, because this is usually related to poor neurodevelopmental outcome. So our goal is to establish normal growth according to the intrauterine growth trajectories. So you have seen this before. These are the growth trajectories from 1999, and what you here can see is that the infants were born on the 15th percentile, and then they were admitted to the NICU, and then they had a massive growth retardation due to poor feeding, poor admission of nutrients. In 2014, we did better. In 2005, the first guidelines for parental nutrition were published, and nowadays you see that they also drop down for 1 to 2 percentiles, but they stay in the range usually. And these are data from the group of Christoph Fuchs, who looked at the physiological growth trajectories of very low birth weight infants. And what they found is that due to a higher proportion of water in a premature organism, infants are born at a higher percentile than their physiological growth trajectory is. So infants are, for example, born at the 50th percentile, and the physiological growth trajectory is 1 percentile below. So that should we consider when we talk about normal growth. How do we monitor growth? I think most of us take the Fenton growth charts. The Fenton growth charts are a mixture of combined intrauterine and extrauterine data. They are available for girls and boys. And they start with the 22nd week of gestation and go until discharge up to the 50th week of gestation. We have also newer guidelines. These are from the Intergrowth 21. This is a WHO study on premature infants. and they represent extrauterine growth. So these are more reliable on the growth of the extrauterine growth of premature infants. They have one disadvantage, and they start at 27 weeks, so there are no data available before 27 weeks, which is sometimes not practical because our infants are smaller. And I also want to introduce you this. This is a very nice growth calculator. You can use this online, also by the group of Christoph Fusch. And what you can do here is you say the gestational age, the birth weight, and the sex of the infant, and then the calculator calculates you the individualized growth trajectory for your infant, and you can print it out and put it in the growth charts and use it for growth monitoring. So it's very easy to use. So now to the guidelines. I'll guide you through the chapters: fluid management, macronutrients, micronutrients, and individualized versus standard PN. So first of all, the physiologic adaptation of fluids. The guidelines differ in 3 different phases according to the adaptation of extrauterine life. So first of all, the transition phase. These are the rearrangement of body compartments. The second phase is the intermediate phase, where the enteral nutrition is established. And the third phase is the phase of stable growth. So what is characteristic, especially for the first phase? So during the first phase, the infant starts with a relative oliguria lasting hours to days, which is followed by a diuretic phase lasting some days, and this is characterized via progressive diminished water loss. We have also a considerable water loss via the immature skin, depending on the gestational age of the infant. The more immature the infant is, the more water the infant loses via the immature skin. And during this transition from intrauterine to extrauterine life, the body fluid compartments are rearranged by isotonic or hypertonic contraction of the extracellular fluid compartment. This phase ends when the maximum weight loss occurs, which is approximately 7 to 10% of the body weight. What our goals as neonatologists during this phase: we should allow to contract the extracellular fluid room without compromising intravascular fluid. So as we heard yesterday or today also, cardiac ultrasound will help in this phase so that the cardiovascular function is established while the extracellular space is going down. We should secure a sufficient urinary output and avoid oliguria, and we should ensure regulation of the body temperature by providing enough fluid for dense transdermal evaporation. And we should consider that fluid restriction or adhering to the guidelines reduces the risk for PDA, neck, and death. I'll come to that back later. And secondly, the fluid restriction tends also to reduce the risk for BPD, but there's conflicting evidence concerning this, if this has really an effect on bronchopulmonary dysplasia. During the second and the third phase of fluid management, we should replete the body electrolyte losses. And during phase 2, we should maintain proper fluid and electrolyte homeostasis while the infant is regaining birth weight. And the third phase, we should provide adequate fluid and electrolytes for growth. What does this mean in particular? The guidelines differ between different groups of preterm infants and term infants. And these days represent the transition phase, the intermediate phase, and the phase of stable growth. And you can see that the highest fluid administration is in the preterm infant with a birth weight below 1,000 grams. the lowest in the term infant, and it steps up during the following days to a maintenance fluid of 150 to 160 ml per kilogram per day for all groups, for almost all groups. And this is much lower than in the former guidelines from 2005. There a fluid intake of 180 milliliters for small infants was allowed. What should you consider during your fluid management? This is also related to your equipment. So double wall incubators reduce the insensible water loss approximately by 30%. Also the use of waterproof coverings such as plastic films, plastic blankets, bubble blankets, they further reduce the water loss in combination with double wall incubators up to 30 to 60%. You should consider that endotracheal intubation makes a difference in your fluid management. Mechanical ventilation using warm and humidified air significantly reduces your fluid requirements approximately by 20 ml per kilogram per day. So when you have a baby on CPAP and you're intubated, go down with your fluid intake. The use of emollient ointments decreases the insensible water loss up to 50%, especially in open care conditions, not in open air conditions. And as I told you before, the fluid restriction or adhering to these guidelines during the first week, especially during the first week, has an enormous impact on the incidence of arteriosus, neck, and death, and also a trend to reduce the risk for BPD. Energy was also one chapter, energy requirements. You have to consider that a premature infant with a gestational age of 23 to 24 weeks has energy resources of approximately 20 kilocalories. A 28-weeker of 250 kilocalories and a 32-weeker of 360 kilocalories. So this is not very much, and not very much energy stores, and therefore you should give a lot of calories to this group of patients. So you start on your first day with 45 to 55 calories per kilogram per day, also in the term infant, and it quickly go up with your calories to establish growth, and this is approximately 90 to 120 kilocalories to gain weight. So this is my first question now before we go on further. Which TPN would you prescribe for a premature infant on the first day of life? Which combination of nutrients? Would you administer glucose and electrolytes, glucose amino acids and electrolytes, glucose amino acids, fat and electrolytes, glucose amino acids, fat, electrolytes and vitamins, and trace elements, or none of these combinations, your own mixture, for example? How would you start? First day of life. Baby is administered is admitted to your NICU. Great. You adhere to the new guidelines, almost. This is recommended now, yeah. So you start on the first day. Okay, you start on the first day. It doesn't work. You start on the first day, and this is recommended since 2005 with glucose, amino acids, and fat. Yes. Now the recommendations for glucose intake on the first day are a little bit more flexible. In the former recommendations, it was only 4 milligram per kilogram per minute. Now there is a higher range. The protein recommendations went down in the recommendations of 2005. It was 2 grams per kilogram per day. So in general, the protein recommendations went down in the new guidelines. And for the first day, it is 1.5. And for fat, it is 1 to 3 grams per kilogram per day. And then you go up stepwise to a target for glucose between 8 to 10 milligram per kilogram per minute, protein to a maximum of 3.5, and fat to a maximum of 4 grams per kilogram per day. So what is new? It is new that the recommendations for protein are a little bit lower now, and this is mainly related that now more and more papers or more and more evidence occurred that if you administer protein with sufficient calories, then the protein intake works, and therefore you shouldn't give that much protein because this can't be metabolized, and this is therefore the recommendations for protein were reduced. So what is important in your carbohydrate management, you should monitor your serum glucose, and your target range is 45 to 145 milligram per deciliter. What is new is in newborn infants with an age below 28 days who have an episode of acute illness such as infection or sepsis, you should temporarily go down for the glucose administration of the first day, so 4 to 8 milligram per kilogram per day, to reduce it during the episode of acute illness. Hypoglycemia is defined as a serum glucose above a level of 145 milligram per kilogram per day. So first of all, of course, you would reduce intake. If you have repetitive glucose levels of more than 180 milligram per kilogram per deciliter, especially in a premature infant, it is recommended to start insulin infusion. Of course, you check your medication, your catecholamines, check if the baby has an infection. That also might bring up your glucose level. IVH has an influence. What are the risks of hypoglycemia? It has an effect on morbidity and mortality. It increases the CO2 production, which is unfavorable for us. We don't want to have a high CO2 because this has an impact on the breathing work of the infant, and it also has an impact on the fat metabolism. So how do you monitor protein? So as said before, the protein intake is strongly related to energy intake. The protein energy ratio is a very important parameter. To deposit 1 gram of protein, a preterm infant needs approximately 10 to 30 kilocalorie energy. Otherwise, they can't gain tissue. So an amino acid supply of 1.5 gram per kilogram is beneficial in preterm infants because they have an increased protein breakdown caused by the antenatal steroid therapy for lung maturation. Sometimes they also get postnatal corticosteroids, which has also an impact on the protein metabolism, and catabolic stress due to illness is also an influence factor. So a minimum intake of 1.5 gram per kilogram per day is always recommended to prevent a negative nitrogen balance and weight loss. And higher intakes need to achieve for a physiological protein deposition. You monitor your amino acid management or protein management by serum protein, albumin, and urea once a week. And sometimes it's also a helpful parameter to do a blood gas, and when you have an unexplainable metabolic acidosis, have in mind that it might be related to a too high protein intake. This can also cause metabolic acidosis, and the solution is to go down with your protein intake. And also the liver function parameters should be monitored once a week when you have a baby on parental nutrition. Next point, the lipids, very important chapter in the new guidelines. I'm sure you all know we have different generation of lipids. The first generation basically based on soy oil. Based on soy oil. Second generation lipids are a mixture of soy oil and olive oil. And third generation lipids are a mixture of soy oil, olive oil, coconut oil, which has a high proportion of MCTs. And there's also part fish oil in it. And we also have pure fish oil, however, it is not it's not approved for infants, but it's also important to mention it. And beside the different ingredients, you have two parameters which are very important. You have the vitamin E content. Vitamin E is an antioxidant for the premature infant, also for the adult, for every organism, and we want to have a high intake of vitamin E. So the new generation of lipids have a higher vitamin E content, which is favorable. And there are also phytosterols in our lipid emulsions, which are unfavorable. Phytosterols inhibit the bile flow and the bile secretion, and can contribute to the parental nutrition associated liver diseases. So the less phytosterol content, the more favorable. So which lipid do you use in your unit? First generation lipids, second generation lipids, third generation lipids, pure fish oil, a combination of two or more, or do you put lipids in your parental nutrition? Oh, interesting. So most of you use a small lipid with this, which is a third generation lipid containing fish oil. You shouldn't do that, I think. And nobody uses pure fish oil, which is also recommended. Pure fish oil alone shouldn't be used. Okay, what is the background? This is a very busy slide, but I guide you quickly through that to the basic information. It is also important that lipid emulsions have different anti-inflammatory properties. And this is related to the ratio of omega-6 fatty acids to omega-3 fatty acids. So omega-6 fatty acids, they are metabolized via different enzymes via arachidonic acid, and they are metabolized mainly to pro-inflammatory. These metabolites have mainly pro-inflammatory properties, and the omega-3 fatty acids, they are metabolized to EPA and DHA, and they have more or less anti-inflammatory properties. So if you have a relation of 6 to 1, like in the first generation lipid emulsions, you have more pro-inflammatory properties. If you have a relation of 3 to 1, like in the third generation lipids, you have more anti-inflammatory properties, and this is favorable. So I'll list you up what are the advantages and disadvantages of the lipid emulsions. So Intralipid, which is a first generation lipid emulsion, has mainly omega-6 fatty acids. But the advantage is we have more than 60 years experience. We know that we can administer it to the babies grow, so a lot of experience is available on that product. It contains many polyunsaturated fatty acids that are peroxidation prone. There is a little vitamin E content in there. They have a high load of omega-6 fatty acids with pro-inflammatory fatty acids in there. They have many phytosterols, and therefore the ESPGHAN recommends not to use them anymore. Second generation lipids contain more immunoneutral fatty acids. The advantages are they are less inflammatory, they are less peroxidation prone, they have a better vitamin E to fatty acid ratio, they have a reduction in phytosterols, but they contain hardly any other long chain polyunsaturated fatty acids. Omega-1 is pure fish oil. This is mainly omega-3 fatty acids, should only be used in combination with other lipid emulsions. It contains a lot of DHA and APA, which are essential for brain growth and brain development. Has anti-inflammatory properties, no phytosterols, and a high dose of vitamin E. You shouldn't use it alone because there are hardly any omega-6 but are very high levels of EPA. There are only 10% solutions available, which is not recommended in premature infant. You should always use 20% lipid emulsions, and you should only use it in a mixed combination. And SMOF-lipid is a balanced mixture of 3, 6, and 9 omega-6 fatty acids. The advantages are that it contains MCTs that are easier energy source without peroxidation. They have the olive oil contributes immunoneutral fatty acids with less peroxidation, a high dose of omega-3 fatty acids, a high dose of vitamin E, but still some phytosterols, and the FDA approves it only for adults in the US. So in the US it's not used yet. Another few words to the lipid emulsions. Well, what the ESPGHAN recommends, you should always establish a minimum intake of essential fatty acids, and this is mainly the linoleic acid of 1.5 gram per kilogram per day, and all of these lipid emulsions that I showed you ensure this intake per day. You should administer it continuously over 24 hours. You shouldn't use soy lipid emulsions anymore. You should use composite lipid emulsions with or without fish oil. For preterm infants, the lipid emulsions should be light protected by special tubes like this one. This is related to phototherapy. Phototherapy makes toxic agents in the lipid emulsion, and this might be a problem again in the parental nutrition associated liver disease. So lipid emulsions should always be light protected, and also for the vitamins which should be added to the lipid emulsions, they should also be light protected. Consider that in pediatric patients, heparin should not be given together with lipid infusions on a routine base. What is also new is carnitine supplementation is recommended again, especially when you have pediatric patients that receive PN for more than 4 weeks, or for premature infants on an individual base, 20 to 30 milligram per kilogram per day. And this is also new in patients with sepsis. More frequent monitoring of triglycerides are recommended. In the former guidelines, it was recommended to stop lipid emulsions when you have a baby with a sepsis. Now you should reduce the lipids to enable a minimum fatty acid supply, but you shouldn't stop it anymore. So this is new. And in patients with unexplained thrombocytopenia, serum triglyceride concentrations should be monitored, and the reduction of parenteral lipid dosage may be considered because there are interaction between the lipid emulsions and the thrombocytes, which can cause thrombocytopenia. Okay, we've also said this, when you have a parental nutrition associated liver disease, you should use composite lipid emulsions, especially with fish oil. There is a favorable effect in this case, and you should monitor your lipid administration via the triglycerides. The target is below 265, and the liver function parameters and conjugated bilirubin should be monitored once a week. When you prescribe parenteral nutrition, there is a discrepancy between parenteral and enteral recommendation. And I want to point out that especially in the macronutrients, protein and fat, there's a difference between the parenteral intake and the enteral intake. And when you have a baby on half enteral feeds, you should consider this, especially the fat intake. The enteral fat intake is much higher than the recommended parenteral intake. So when you have a baby on half enteral feeds, your target should be somewhere here in between. Just to consider this, especially then when you used computer software to prescribe your parenteral nutrition and you have target values there. So consider this, you have a baby on half of enteral feedings, and these are not the right target values for your parenteral nutrition then. Okay, then the electrolytes. Just a few words on that. Sodium and potassium is recommended from the first day on. Very complicated here. The increase of sodium intake. The ESPGHAN recommends now a higher intake of sodium. You should avoid hyponatremia because this increases morbidity and mortality in premature infants. And I think this is one of the changes with the highest impact is related to calcium and phosphor. You can see calcium and phosphor as well as magnesium is recommended from the first day on. But what has changed is the ratio between calcium and phosphor. And you can see that this is almost 1-to-1 now. And I come back to that. During the first days, calcium, phosphor and magnesium should be provided with a light surplus. And then the intake for the growing stable infant is higher than in the former recommendations. The ratio has changed. The ratio now is 0.8 to 1.0. In the former recommendations it was 0.3 to 0.7, so much more calcium than phosphor. And it's recommended to use organic salts, which is, I think, very common in Europe. And you should monitor your calcium, phosphorus and magnesium intake by the serum values, by the alkaline phosphatase, which is a very nice parameter in the neonate to monitor your bone healthiness. You should also monitor the calcium and phosphorus output in the urine. And vitamin D, you should only check once a month if you have an infant on long-term parenteral nutrition. Okay, so phosphor, especially in the infant with an intrauterine growth restriction, you should consider that they might become hypophosphatemic. They suffer from a kind of refeeding syndrome, and I come to that in the next slide. What is the pathomechanism behind this? So especially in intrauterine growth retarded infants, you should monitor your phosphor very carefully, because hypophosphatemia can result in muscle weakness, in respiratory failure, cardiac dysfunction and death. And you should consider that infants whose mothers got some antenatal magnesium infusions might start with higher magnesium levels on the first day of life. And what is the background behind this new calcium and phosphor ratio? So when you have a calcium and phosphor intake, from the calcium, 98% of your intake goes into the bone, but only 80% of your phosphor goes into the bone. The other 20% go into the tissue. So when you have a fetal accretion of 3.4 millimole per kilogram per day, 89% go to bone mineralization, and from the 2.6 millimole per kilogram per day, 80%, which is approximately 2 millimole per kilogram, go into the bone, and 20% is needed for tissue accretion. You need approximately to metabolize 1 gram of protein, you need 0.3 millimole of phosphorus. So when you have a baby with a parenteral intake of 3 gram protein, you need 0.9 millimole phosphorus for protein metabolism and tissue accretion. Therefore, not all the phosphor intake is available for the bone, and therefore the ratio has changed. I hope this was clear for everybody, because this is a real new impact in the new guidelines. Concerning the vitamin, again, this is a very busy slide. I guide you through the highlights. These are the fat-soluble vitamins. These are the water-soluble vitamins. These are the requirements for preterm infants, for term infants. What has changed? Nowadays, there's a much higher intake for vitamin D recommended. In the old guidelines, it was 40 to 160. Now it's much more. And this is a problem, because our mixed vitamin solutions, also when you go up to 4 milliliter per kilogram per day, you can only administer 160 units per kilogram per day. And I think the solution is to start with your enteral vitamin D supply very early to achieve these values in the premature infants. Trace elements, the new guidelines recommend, especially for zinc, a higher intake, 400 to 500, and for selenium as an antioxidant, also a higher intake. The problem is we do not have any trace element preparation in Europe that fits the achievements, the requirements of the premature infants there. So this is an unsolved problem yet. A further focus is on manganese. Manganese is a trace element which contributes to the parenteral nutrition associated liver disease, and therefore the daily enteral intake shouldn't exceed 1 microgram per kilogram per day. So if you have an infant developing cholestasis, then take care of the manganese intake. It shouldn't exceed this daily volume. So the last point is on standardized versus individualized parenteral nutrition. Do you use it in your unit? Do you use it always? For almost all patients, sometimes in uncomplicated patients, only on the first day of life with a starter solution, or don't you use it at all? So standardized parenteral nutrition is ready-to-use bags, commercially available, prepared by your pharmacy. Individualized is the parenteral nutrition you prescribe on a daily basis. Okay, so a very high proportion of people use it for most or for all the patients. Again, you are according with the ESPGHAN guidelines. The new guidelines recommend that standardized parenteral nutrition solutions should be used in a majority of pediatric and newborn patients, also including very low birth weight infants. And the individually tailored parenteral nutrition should only be used in very unstable, very sick patients that are metabolically unstable, that have electrolyte losses, such as infants with short bowel syndrome or similar conditions. And they also recommend computerized prescription, whether standard or individualized. It should be used in the ordering process of parenteral nutrition whenever possible. This reduces production mistakes, this reduces prescribing mistakes, and improves the safety for your patient. And I'm sure there are some of you who don't believe that you can deal with ready-to-use solutions in most all of the patients, and this is the Australian model. Australia has published it in 2014, and I think it is used in almost all units. There are 7 standardized parenteral nutritions available. I'll show you 3 here. This is the starter solution with low sodium and potassium for the first days of life. This is the standardized parenteral nutrition for central line. It additionally contains zinc, selenium, and iodine. And this is the standardized parenteral nutrition for peripheral line, and these are low calcium and phosphorus content. And they combine the amino acids and glucose bag with the electrolytes with a fat bag. The fat bag contains a second generation lipid emulsion with water solubles and fat solubles vitamins. And the dosage is 1 gram per kilogram per day. This is 6 milliliters, and they started immediately after the infant is admitted to the unit. And it works. In Europe, we have 1 commercialized parenteral nutrition bag available. I think you can also see him outside with a fat chamber, amino acid chamber, and a glucose chamber, and you activate it immediately before you use it and put it on the bedside. So very easy. So the take-home message from the new guidelines. Start with macronutrients and micronutrients immediately after birth. Vitamins, electrolytes, glucose, amino acids, and fat, like most of you do. Adhere to the different phases of postnatal fluid management and avoid excessive fluid intake. This increases morbidity and mortality. Remember the higher neck incidence. Remember the higher mortality associated with a very high fluid intake. Use 2nd and 3rd generation lipids due to their anti-inflammatory properties and for the prevention of parenteral nutrition associated liver disease. Keep in mind that there is a new ratio of calcium to phosphorus. This is now 0.8 to 1.0 to avoid symptoms of a refeeding syndrome. Use a computerized software for prescribing TPN and use standardized TPN whenever possible. Thank you. I'm happy to take your questions.